Hi, everyone. My name is Lauren, and my research is focused on personalized risk prediction for heart disease using computed tomography or CT, like in this clinical setup here on the left. My PhD was focused on detecting calcium in the coronary arteries, which is a sign of coronary artery disease. The first thing I asked was, when should a patient undergo a first CT scan to screen for coronary calcium? And by combining genetic, imaging, and epidemiological data, I calculated an individual's probability of coronary calcium as a function of age and genetic risk. I found that a male with high genetic risk, represented here by this purple curve, reaches a 25% probability of calcium around age 39, whereas a male with very low genetic risk, represented by the red curve, reaches that same 25% threshold around age 52. And we can use this information to target especially high-risk people for early calcium screening with CT. I also wanted to know if we could detect calcifications earlier in the patient's life, when those calcifications are smaller. But calcium detectability on CT depends on a lot of different parameters, ranging from the physics of the scanner to the size of the patient. So I developed a computer simulation to calculate a highly accurate estimation of the calcium signal, or CT image intensity, shown here on the y-axis, for a range of calcium granule sizes, shown here on the x-axis. The blue dots here are the results of the simulation, and the green and red markers show experimental results from the scanner. With this data, we now know both the limit of detectability of the calcium scanning protocol that's currently used in the clinic, and we know how to optimize imaging parameters to improve that protocol and identify high-risk people earlier in life. For my postdoc, I've turned my focus to risk prediction for stroke in patients with atrial fibrillation, or AFib. In AFib, the heart's upper chambers beat irregularly, and that causes regions of irregular blood flow in the left atrium, which is composed of the left atrium main chamber, shown here in the center in orange, and an appendage that protrudes from it called the left atrial appendage, or LAA. Patients in AFib are at a 5 times greater risk for stroke compared to the general population, and 90% of their strokes are caused by clots that form right here in the left atrial appendage. With recent advances in 4-dimensional CT, or 4D-CT, we can visualize blood flow through the heart by injecting a patient with imaging contrast agent and then watching a video from 4D-CT as the heart fills with contrast. Then, using an analytical model of contrast transit time and computational fluid dynamics in collaboration with researchers at the University of Washington, we can quantify blood flow parameters like blood residence time into patient-specific 3D maps of the left atrium and the appendage. We've already begun to quantify some of these parameters. For example, here on the bottom right is a cross-section through the left atrial appendage of a patient, and the brightness of this map is proportional to how long it takes for contrast to reach its peak intensity in each pixel. We see that this distal part of the appendage is yellow, meaning there's a delay in filling, whereas the appendage for this patient on the top fills relatively uniformly. And this could be really valuable information for patient-specific risk prediction. But to compute a map of blood residence time, it currently takes about a week per patient using a supercomputer. So to make these maps in a large patient cohort or in the clinic, we need a much more efficient way to do so. And that's where I think AI could make a huge difference. I'd like to apply AI to generate these 3D transit maps of very complex flow automatically from 4D-CT data and improve risk prediction for stroke.